Bismillahirrahmanirrahim. Lacrimal system pathology and assessment. Watery eye means lacrimation, lacrimation or epiphora obstruction. If the patient is watering, so he has either over lacrimation or obstruction in the drainage. The lacrimation uh, may be due to emotional conditions, reflex lacrimation due to foreign body uh, impacted in the eye, or inflammation of the lid margin, conjunctivitis, corneal ulcer, iritis and ciliary body inflammation, glaucoma, and aesthetic surgery. Epiphora means that the secretion is normal, but the obstruction is the problem. So epiphora is an overflow of tears onto the cheek due to decrease in the drainage. The etiology may be non-obstructive or obstructive. Non-obstructive means lacrimal pump failure, as in patients with facial palsy due to loss of the tone in the orbicularis oculi, including the muscle that is responsible for the pump, or due to malposition of the lid. So the lacrimal stream does not go in its normal pathway to the lacrimal punctum. These are the causes of non-obstructive epiphora. The obstructive epiphora means that there is obstruction in the drainage pathway, starting from the punctum down to the opening of the nasolacrimal duct. The obstruction may be congenital, as in punctal atresia or congenital nasolacrimal duct obstruction, traumatic, after trauma, which leads to collapse of the bone fractures and surgical trauma, inflammatory, as in trachoma, herpes, and fungal infections, tumors, which obstruct the opening of the nasolacrimal duct in the nose, as in nasal polyps and maxillary tumors, and sometimes foreign body may lead to obstruction. The evaluation of the case of watering includes investigation. The clinical test called the regurgitation test is the milestone in these conditions, in which we compress the lacrimal sac and notice if there is regurgitation of fluid, either watery, mucus, or mucopurulent from the punctum. Fluorescein dye disappearance test, which is performed by installation of fluorescein drop in the conjunctival sac, and a cotton pad is put under the inferior turbinate, and we notice the free fluid of fluorescein and staining of the cotton pad. Or lacrimal irrigation, in which we inject fluid from the upper punctum or lower punctum and notice if it is regurgitating from the other punctum or passing free in the nose. Sometimes we investigate by imaging, as in dacrocystography, in which a radio contrast medium is injected in the lacrimal system and an X-ray is performed. It shows the level of obstruction of the site affected by epiphora. Plain X-ray for diagnosis of tumors and fracture may be performed. Treatment of epiphora includes treatment of the according to the level of obstruction. We will deal with it. Here is some details about these conditions. Congenital nasolacrimal obstruction, or congenital or infantile dacrocystitis, is usually occur due to imperforate Hessner's valve, which is the last valve in the lacrimal system at the junction of the nasolacrimal duct and the nose. Clinically, the patient presents with epiphora. The parents say that this child, dating since birth, soon after complains of epiphora and discharge, usually starts 2 to 3 weeks after birth, because in the first 2 to 3 weeks there is delayed secretion of the lacrimal sac and lacrimal glands. So even if there is an obstruction, it will not be noticed. Pressure on the sac revealed a positive regurg, which means regurgitation of fluid from the lacrimal sac. This condition is treated in the following schedule: conservative treatment, which means follow-up, topical antibiotics, and hydrostatic massage to the lacrimal sac in order to drain the fluid and in order to increase the positive pressure inside the sac, which may help in opening the nasolacrimal duct. If the patient is not responding to the conservative treatment and spontaneous canalization doesn't occur after 6 months to 1 year of age, probing is performed, and in this probing we probe the lacrimal system starting from the punctum down to the nasolacrimal duct. Repeated syringing and irrigation may open the obstruction. If this fails, we perform probing and put a silicone stent inside the nasolacrimal system in order to maintain this opening for 3 to 6 months. Then it is removed. And in failed conditions after conservative treatment of probing and silicone intubation, the solution will be bypassing surgery. We will let the nasolacrimal duct in its place, and we will bypass the pathway of obstruction by performing the dacryocysto-rhinostomy or DCR. The second topic is the chronic dacryocystitis. In chronic dacryocystitis, it is an chronic inflammation of the lacrimal sac secondary to obstruction of the nasolacrimal duct, and it is the commonest lacrimal sac disorder. The etiology, usually the cause is nasolacrimal duct obstruction, and secondary infection, which is usually pneumococci in 80% of cases, but other organisms like staph, strep, and trachoma may be the cause. The patient presents with watery eye and discharge. You will notice a swelling of over the lacrimal sac below the medial palpebral ligament and positive regurg test. In this condition, it may be complicated by chronic conjunctivitis, epiphora, which leads to eczema of the lid around the eye. This patient is liable to infections, ocular infections like hypopyon ulcer, endophthalmitis following intraocular surgery because there is a septic focus inside the lacrimal system. The obstruction may affect the upper lacrimal system also, and this will lead to formation of a mucocele or biocele. And if the obstruction becomes upper and lower, lacrimal vistula may result. The investigation are the same as we described before. The treatment of this condition is only surgical, dacryocysto-rhinostomy, and in this operation we create a bypass between the lacrimal sac and the middle turbinate. We will remove the intervening bone, remove the medial wall of the sac, and remove the medial mucosa and perform an anastomosis. Dacryocystictomy means removal of the whole sac. We will not perform a bypass surgery, but we will remove the whole sac, and it is indicated in certain conditions, like bad lacrimal sac, extensive adhesions, and neglected cases in which we cannot perform the bypass, bad nasal mucosa, atrophic rhinitis, and nasal polypi, and cases of tumors or very old age, which you cannot perform the surgery of bypass. The second topic in adults is the acute dacryocystitis, which is an acute suburethral inflammation of the lacrimal sac. Acute suburethral inflammation of the lacrimal sac. Also, the predisposing factor, like the chronic one, is the nasolacrimal duct obstruction, but the organism is usually pneumococci and strep. The patient in acute dacryocystitis presents like the acute abscess, like the abscess. He presents with severe pain, and fever, and swelling at the site of the sac. This is marked edema and over the skin of the sac. Regurgitation test in this condition is usually negative because the edema affects the upper lacrimal system, and this will obstruct the regurgitation of fluid. There's tenderness over the sac and abscess formation. This may be complicated by formation of lacrimal vistula, mucocele and biocele if the obstruction affects the upper system. Secondary infection like orbital cellulitis, which may be complicated by another serious condition if the infection extends to the cavernous sinus, which is the cavernous sinus thrombosis, and the acute condition may resolve but results in chronic dacryocystitis. The treatment of the acute condition is like the abscess. We give the patient systemic antibiotics, topical antibiotics, hot fomentation, cleaning of the pus, and incisional drainage if an abscess is formed. After resolution of the acute attack, we will perform the DCR, dacryocytorhinostomy. Canaliculitis is a variety of infection of the lacrimal system which affect the upper lacrimal system, the canaliculi. It may result from fungal infection or biogenic organisms. And in this condition, the patient presents with persistent epiphora, not responding to the ordinary treatment, chronic conjunctivitis at the medial canthus, prominent and dilated lacrimal punctum, and on pressure, a mucopurulent discharge, which sometimes contains concretions, will extrude from the canaliculi. The treatment is to drain the canaliculi by canaliculotomy. We incise the canaliculi and drain the material collected inside it and curate it and use topical antibiotics. Here we covered the watery eye, whether it is due to over-lacrimation or it is due to obstruction. The second arm of the lacrimal system disorders is a dry eye. Dry eye may be congenital absence of the lacrimal gland, may be due to inflammation of the lacrimal gland, so its secretion is delayed, like in case of sarcoidosis. And in patients with lacrimal gland tumors, like mixed lacrimal gland tumors, in which we are obligated to remove the lacrimal gland. Autoimmune diseases like keratoconjunctivitis sicca is an autoimmune disease leading to atrophy of the lacrimal gland. It's more common in females and may be associated with arthritis and dry eye, and it's called Sjogren syndrome. Conjunctival scarring due to trachoma, diphtheria, chemical burn, Stevens-Johnson syndrome, and cicatricial pemphigoid, which is an autoimmune disease in old age. Clinically, the patient with dry eye presents with foreign body sensation because the layer which smooths the movement of the lid over the eye is not present. So the patient complains of foreign body sensation, deficient tear production, which is measured by the Schirmer test. Rosebengal staining of the ocular surface results, which stains the degenerated cells of the conjunctiva and the cornea, show staining of these cells, which means it is pathological cells. Punctate epithelial erosion of the cornea, and tear film pre-cap time is diminished. The treatment is protective goggles to protect against dryness of the already deficient tear film. We use topical tear substitutes, are drop and gels. Occlusion of the punctum to preserve, whenever possible, the lacrimation which is already deficient. And in autoimmune disease, we are using the steroids. And thank you.